Good morning, everyone. Welcome to Yashoda Hospitals Health Talk session. With the COVID cases increasing in our country as well as in the state, we are here today to talk about coronavirus and blood clots. So get your questions ready and post them on our social media network. I'm Dr. Lakshmi, and today we have with us Dr. Chetan, consultant pulmonologist, and Dr. Ganesh, consultant hematologist and bone marrow transplant physician from Yashoda Hospitals, Somajiguda. Welcome, sir. So, doctor, with the country seeing a surge in the number of COVID cases at a rapid rate, and now that there is studies saying about the double mutant and now about the triple mutant, so what do you have to say about this?
So yeah, the second wave probably is because of the double mutant variant initially when it started, and definitely it started with a very atypical presentation as compared to the first wave, and we have seen that it is more contagious, more infectious and early progressing variant when compared to the first wave virus. So now this wave, initially it started with all GE symptoms like loose motions, vomiting, so which actually the practitioners were misled. So they were not actually thinking of COVID, and then once it became rampant, then we realized these are also symptoms of COVID, which we didn't see in the first wave. And the second difference now which we see is patients are presenting with uncontrolled fevers and uncontrolled cough in the first week of illness itself, despite of all the maximum therapies. We are seeing people panicking everywhere, running around the CT scan centers, running around for remdesivirs and all, which actually is not required at this point of time. Some amount of patients in the mild to moderate disease would actually be better.
So, sir, did you see that this time the presentation is different compared to the previous wave from the blood clots point of view?
Yes. So, thank you, Dr. Lakshmi, for bringing that point out here. From hematological perspective, what COVID is like the many phenomenon or the symptoms of COVID are similar to certain manifestations of patients undergoing bone marrow transplant. So, it's kind of, rather than the COVID virus causing major damage to the body, it's our human body response, the antiviral or anti-inflammatory response, what we call it as, against the virus, which can go haywire and which can go uncontrolled and which can cause all the major serious effects of COVID infection on our body. So basically, the COVID viral infection causes the inflammation of the blood vessel lining, right. So in medically we call it as endothelium. So endothelitis is the inflammation of the blood vessel wall. Endothelitis leading to thromboinflammation. So that's how the clotting is one of the major manifestations in COVID infection. So why these markers are important? These are the markers of inflammation, and D-dimer fibrinogen are markers of coagulation, right. So inflammation and coagulation goes hand in hand. So those patients with high marker levels are the patients at high risk of extensive coagulation, clotting, and these are the patients which need blood thinners to check that excessively active coagulation in check, so that the patient does not get the major troll or the major life threatening side effects of clotting in patients with severe COVID infection.
Let's take few questions what we've got from our audience asking us on our social media platform. We have Mr. Pavan asking from Warangal. He wants to know, is Remdesivir beneficial in the treatment of COVID in this variant?
Okay, I think this is a very apt question at this point of time, because last few days, right from morning, we have calls, messages regarding remdesivir availability, people running everywhere for remdesivir. So actually, is it really helpful is a big question for us also, because there are still so many studies going on remdesivir in larger population. So last year when remdesivir was released and approved by FDA for emergency use, we were also thinking like it is a big breakthrough in the treatment of COVID. But to our surprise, most of the major studies from the Western world proved it to be wrong, and they said that remdesivir actually doesn't help. So remdesivir, being an antiviral, theoretically helps only in the first week of illness, which we actually call the viral phase of illness. So once the patient crosses the first week of illness, and in the second week when he lands up in the inflammatory phase, theoretically remdesivir has no role. So most of the admissions in the hospital happen in the second week of illness. So thereby theoretically remdesivir will not be of much help. and all the major studies prove that remdesivir has no mortality benefit. That is, remdesivir will not prevent the patient from dying. So the only benefit it has is it decreases the number of hospital days.
So similarly, sir, we have newer studies stating that the stem cell therapy is beneficial in treating the COVID infections. Did you clinically see them to be beneficial?
So any patient with immunocompromised status with these viral infections, opportunistic infections, so there is something called as cellular virus directed immunotherapy, right? So you collect the the lymphocytes which are trained to act against the virus infected cells, and that's one part of immunotherapy. People are confusing it with stem cell therapy. So that is one part. So cellular immunotherapy, yes, it has worked in many serious viral infections in the arena of transplant. So it might work in coronavirus infections also. Apart from that, there is something called as an experimental phase of stem cell therapy, wherein they collect the umbilical cord blood stem cells, which are immunologically naive stem cells, or mesenchymal stem cells, which helps to heal the affected part by the COVID infection. It is postulated that these immunologically naive stem cells will go to the area of affected organ and will regenerate the damaged cells, and that's how it might work. But then there are some preliminary reports coming from mostly from China and Europe and North American continent. The preliminary reports seems to be promising, but we cannot conclude what is the effect. The promising result is either due to stem cell therapy alone or other associated therapies and supportive care offered in the COVID-19 infections.
Okay, moving on to the questions, we have Mr. Srinivas asking us from Karimnagar. He is asking, what are the long-term complications one can expect after recovering from COVID pneumonia?
Something pertaining to the lung, first thing is lung fibrosis, especially seen in patients who had severe COVID pneumonia or ARDS and were on oxygen support or ventilator support for quite some time. So initially when we were seeing COVID patients in the last wave, we thought this fibrosis would be permanent, but surprisingly we are seeing lungs getting back to normal slowly, maybe over a long period of time. The other infective complications post-COVID we see are tuberculosis and fungal infections like mucormycosis, because in the management of severe COVID we have to give them steroids so that the inflammation is suppressed. And there is a practice of giving tocilizumab also, which is again an immunosuppressive therapy. So both these therapies make the patient more vulnerable to these communicable diseases like tuberculosis and the more fatal fungal infection called mucormycosis. So these are some long-term complications pertaining to the lung. Patients might also have reactive airway disease. They present to you like a bronchial asthma. So we also treat it as like bronchial asthma and we label it as post-viral bronchial hyperresponsiveness. There are other vascular complications like pulmonary thromboembolism. There are neurological complications. Patients might present after the viral phase like with symptoms like Guillain-Barré syndrome. We are seeing psychological complications, patients landing up in insomnia, depression and all. And there is something called post-COVID fatigue, which can last up to months together. So in post-COVID fatigue, there's nothing much we can offer, just give them some reassurance and symptomatic therapy. But we always have a close watch on infectious complications post-COVID like tuberculosis and mucormycosis, because they are curable when you start treatment in the early phases.
So doctor, now that to our understanding that we have seen the formation of blood clots during the infection and post-recovery, how do we prevent the formation of blood clots?
So those with less than 3000 D dimer without any evidence of blood clotting, they are given routine low dose prophylaxis like heparin, low molecular weight heparin 0.5 milligram per kg during the entire course of hospitalization, and after post hospitalization at the time of discharge 1 week of post hospitalization anticoagulation or blood thinning. Whereas those with moderate risk of blood clotting, like those having D dimer more than 3000 without evidence of any overt or laboratory evidence of blood clotting, they are giving anticoagulation at a therapeutic range, 1 milligram per kilogram of low molecular weight heparin during the entire hospitalization, followed by 2 to 6 weeks of blood thinning medications after discharge. And those with severe clotting tendency, like those who have established already detected to have blood clots in either in the legs, arms, or in the chest, or anywhere in the body. So, those are given aggressive anticoagulation along with antiplatelet drugs, and there, like just like any other unprovoked clotting in the recommendations are after discharge 3 to 6 months of anticoagulation or blood thinners for 3 to 6 months. Of course, there is no robust science or robust studies behind this, but this is based on many observational studies across the globe, and this is how we prevent the blood clots and the blood clot associated complications in COVID patients.
So, in certain cases, sir, where giving blood thinners is contraindicated, how do you manage in such patients?
Correct. So, one of the common contraindication, of course, many of the severe COVID infections have mild to moderate thrombocytopenia, low platelets. Now, on one hand, having low platelets and on another hand continuing blood thinners is little difficult clinically, because blood thinners and these patients having any bleeding, like bleeding in the gut or bleeding from the nose, mouth, or sometimes serious internal bleeding like bleeding in the brain, can be life threatening when the patient is already on blood thinners and patient also had coexistent low platelet count. So, for patients with platelet count less than 50,000, you have to devise anticoagulation smartly, low molecular weight heparin at 0.5 milligram per kg. Normally, for blood thinners to be continued, platelet count requirement is at least 50,000, but those who have less than 50,000 platelet count, most of these have, just like any viral infection inciting a hematological disease called as ITP, where body's own antibodies starts attacking the platelets and destroying the platelets, that's immune thrombocytopenic purpura, and there the blood thinners you have to devise based on the risk benefit ratio. If the patient based on the lab parameters of D-dimer, fibrinogen and patient's clinical severity, you have to devise the anticoagulation, and if the patient has severe COVID pneumonia and coexistent severely low platelet count, anticoagulation with platelet transfusions is something which is recommended at these serious circumstances.
So, moving on to the next question, we have Mrs. Geetanjali asking us from Mehboob Nagar. She says that she is known asthmatic and on regular medications. So, that does predispose her to getting COVID?
Yeah, again a very common question which we pulmonologists face in our day-to-day practice. Are asthmatics more prone for COVID? I say the answer is no. Asthmatics or per se COPDs are not prone for or not at high risk of acquiring COVID infection, and even if they acquire COVID, it doesn't mean that they get a severe disease. So, they just behave like the regular population. So, asthmatics are told to control their asthma with the regular medications that they use. They are not supposed to skip any medications with the fear of COVID infection, and even if they acquire COVID, the treatment continues to be the same. And now the newer studies, there is a breakthrough saying that the inhaler, budesonide inhaler, which is actually used for asthmatic treatment, is helping in COVID. So in this way, particularly patients with persistent cough and persistent fever, we are giving budesonide inhalers so that they get symptomatic relief. So that way, it is a benefit for asthmatic patients that their inhaler is also helping them in decreasing the symptoms of COVID. So yes, asthmatics are not at high risk of COVID and they are not at high risk of severe infection of COVID.
So similarly, sir, are there any blood group disorders or any particular blood group which is more prone to get this COVID infection?
Yes, that's an interesting question actually, but there is no robust scientific rationale behind some particular blood group being exposed or predisposed to getting COVID infection commonly. Of course, based on the various observational studies, one of the associated finding was that patients with blood group O positive, ORH positive seem to be affected more and seem to have more moderate and severe disease, but that we feel probably just an observational fact or finding. Also the fact that O positive blood group is commoner compared to other blood groups. So, as such there is no proven rationale that one particular group will be more prone to acquiring COVID infection or developing more severe COVID infection as such.
So, is it safe to donate blood, or when should one donate blood after recovery from COVID infection?
So, normally as per the various guidelines, the person who has recovered from COVID infection, at least 6 weeks gap from the negative PCR report or complete resolution of COVID infection, documented 6 weeks gap is mandatory for these persons to donate blood or blood products to required personnel.
Moving on to the next question, we have Mr. Naresh asking us from Nanded. What is the role of lung transplant in treating COVID patients?
Again, a very good question. I think now the numbers of lung transplant are on the rise, especially in Hyderabad. Now I think there are too many active transplants happening. So when coming to COVID, lung transplant actually has no role in active COVID. You're not supposed to do a transplant when the patient is in active COVID. So lung transplant is an option for people who have been on ventilator for quite some time and are having a severe lung damage, which we call severe lung fibrosis. So only then we look for a lung transplant. So again, there are very specified criteria for choosing a candidate for lung transplant, like age, comorbidities, and his general condition, critical care, illness, myopathy and neuropathy and all, everything is taken into consideration. And also you have to think about the post transplant consequences. So it is not an easy thing, but yes, definitely lung transplants are happening for the post COVID complications like post COVID pulmonary fibrosis. So ideally 2 consequent RT-PCRs are supposed to be negative, and then the patient should be free of any other secondary infections like secondary fungal or bacterial infections, and the patient is optimized on ECMO maybe before the transplant while awaiting the donor lung, and then the transplant happens. So it is a very cumbersome process, but yes, definitely lung transplant is seen as an option for irreversible lung injury post COVID.
So that brings us to the end of this session. Thank you all for your active participation, and we do look forward for joining us on next Sunday. We will post the topic shortly. Take care and have a good day.